It's my pleasure to introduce Dr. Emily Levitan this morning. She's going to provide an introduction to epidemiological principles that are central to human-based translational research. Dr. Levitan is the acting chair in the Department of Epidemiology here at UAB. She had got her undergraduate degree at Brown University in Providence, Rhode Island, and then a PhD at Harvard University and postdoc, I've forgotten where, sorry.
Harvard Medical School.
Harvard Medical School. She's been at UAB for quite a long time now. She's been very active in most of our human studies-based research centers. She's had particularly strong interest in cardiovascular disease, but really has participated across most aspects of the UAB community. She's been extremely dedicated to teaching and to making epidemiological principles open to members of our community. She participates in the clinics that allow people to bring in their sort of semi-formed projects for discussion with a well-trained epidemiologist and with biostatisticians as well. And so it's a great opportunity for us to have her introduce you to basic epidemiologic study design. So thanks very much.
Thank you very much for inviting me. It's really a pleasure to be here. Please, if you have any questions as I go along, please stop me and let me know. This stuff I get really excited about, so I can start going too fast. So please slow me down. As David said, I think that teaching and mentoring developing investigators or people who are developing into epidemiology from other fields is a really important part of what I do. So I really like that part. Okay, so just to talk what we're going to talk about today. So first I'll just go over a little bit of what epidemiology is. Some of the core types of epidemiologic studies that we do. These aren't the full breadth of things that you can do with epidemiology, but this is sort of the basic set. Talk a little bit about correlation and causation, developing a testable hypothesis, designing an epidemiologic study, and then some resources for where you can go if you are going to do this kind of work. So to start with, what is epidemiology? So one of the sort of classic definitions is the study of the distribution and determinants of disease frequency. Epidemiology as a formal field is not that old, so 1970 is actually pretty old for epi literature, but there's some stuff that goes back farther than that, but as sort of a separate discipline from medicine or other parts of public health, it's not really that old. When people ask me what I do, I say I study health and disease at a population level, or that I'm studying people in their environments to see what might cause diseases. There are kinds of questions that we ask. So the basic ones, how many people have a disease? So we're trying to count. How many people are developing a disease? So if you start from a population where people are healthy or well, how many of them are going to go on to develop that disease? How quickly are they going to develop that disease? Particularly when we're talking about mortality, right? Everyone's going to die. What we care about is when they die. And then who are they? And then really, what a lot of our studies are trying to get at is cause, right? So what causes disease? It's always a little tricky. That's the thing that's sort of always our challenge in epidemiology, right? Because we're not controlling people. People are all over the place. It's a lot easier to control the setting or the experimental conditions when you're talking about mouse models or if you're talking about cell cultures. And even when you're talking about clinical trials, right? When we're talking about people living freely in their environment, all kinds of stuff goes wrong. I'll talk about that a little bit more later. We define disease broadly. So a lot of people, if they've heard of epidemiology and are not
All right, can you please mute if you're not into the question?
So when we are talking about diseases, we're talking about all kinds of different diseases, all sorts of health conditions that may impact people. So, when people are not sort of confused with dermatology and epidemiology, their rashes, a lot of people in sort of the general population are thinking about infectious disease. who are on the news right now talking about the flu outbreak, or a couple years ago we're talking about Ebola and Zika. But really it's broader than that. We're talking about chronic diseases, injury and violence, and other types of health conditions that affect people.
Sorry about that.
No problem. Okay, so epidemiology is interdisciplinary in nature. So I've sort of set this up like epidemiology is the center of the world. I don't actually believe that. But we do really draw from a wide variety of different disciplines. So medicine, biology, statistics, logic, economics, psychology, sociology, sort of depending on what types of questions we're trying to answer. The other thing is that we are by nature collaborative. So I have never published anything as sole author, and I've never published anything with just epidemiologists on the paper. So usually an epidemiology study will have at least one epidemiologist, hopefully. People from medicine, people from statistics, other fields, depending on what the question is, so that you really get a broad range of views going in. So that's one of the things that I really like about it. I've gotten to learn a lot and work on a lot of different types of projects with a lot of different people. Okay. So sort of the basic type of epidemiology that we do is surveillance. And honestly, this isn't something that most of the people in an academic setting would do. Because that's really sort of the health department role, or the hospital epidemiologist. Because what they want to know is how many people have a disease or how many people are developing a disease. So how many people have a disease at any given point is called prevalence, and how many people develop the disease is called incidence. We do have some people who do this type of work, but by and large, this isn't what, if you went over to the Department of Epidemiology, this isn't what we would be doing on a day-to-day basis. So as an example, a couple years ago, there was a Zika outbreak on the island of Yap in Micronesia. And so this is a small island, a contained population. So if you wanted to know, what is the penetrance or prevalence of disease or infection in this population, it's pretty easy to do because it's only a couple thousand people. There are, a limited number of health settings. And so both because of interest in this particular outbreak and because there was concern that this would spread and did in fact spread later, a couple years later, there was a concerted effort by the CDC in collaboration with Micronesia to do a really good surveillance study. So they did two things, right? So they looked at antibody prevalence. So that is going in and seeing how many people have ever been infected, roughly speaking. And then they also looked at disease incidence over a period of time. So for the prevalence, they did a sample of 200 of the 1,276 households on the island. And they went to these households and drew blood, and then interviewed the people living there about symptoms that they thought would be relevant to Zika. So when they looked at this, of the 557 people they tested, 74% had anti-Zika IgM antibodies, right? So these people had been exposed to this virus, and that's a very high prevalence, clearly. But when they looked at how many people who had been exposed actually reported symptoms, it was only about 38%, right? So this suggests that there's a lot of subclinical disease going on. And then you also look and you see that 19% of the people who were not positive for the antibodies reported having symptoms, right? So what might explain that finding, that almost 20% of people who didn't have evidence of infection had the symptoms?
But other viral infection can be similar with the Zika infection symptoms.
Right. So that the symptoms are not very specific, right? That there might be all kinds of different viruses that could cause these symptoms.
And just going out and interviewing them and asking them if they had symptoms.
Yeah. Right. So asking people, right? How you ask the questions is important. You know, I don't actually remember how exactly they did that, but that is something that when you're designing a study, you do need to think about, right? So sometimes you'll have in there distractor questions, or you'll have the interviewers very highly trained so that, you know, they don't, to not give any sort of unintentional positive response to answering the questions the way they think they should be answered, because that is certainly an issue. Also, the test might not have been perfect, right? So people tend to like these sorts of blood tests because they're, you know, objective measures, but they don't always work right? So if you think about how this test was done, right, they're collecting blood samples out in the field, right, and then shipping them to Atlanta, right? So this is a CDC study, and then doing the testing, right? So things can go wrong at any stage there, right? And then also, and then the testing can go wrong too. So tests are not always perfect. So there's probably some combination of, you know, these symptoms being not very specific, the test being less than perfect, and just asking people questions can encourage them to report symptoms.
Now, the testing being imperfect, that probably would decrease the number. So, the test or the moving of the serum samples, if the problem occurs there, the number would be actually lower than what it is, not higher than what it is, right?
Well, it depends, right? Because you can have false negatives and false positives, right? So if you have false negatives, let's see if I can figure out, okay. If you have false negatives, right, you wind up people in this 143 who actually had been infected. If you have false positives, you wind up with people in this 414 who were truly not infected. So things can go wrong in both directions. Other questions, thoughts about this? Their next step, so this is the same study, next step was that they went to all of the medical records of all the health facilities. Right, so this is one hospital and 4 medical centers on this island. And they came up with a case definition. Right, so their first case definition is they're going through all these medical records. They're looking for rash, arthritis or arthralgia, and conjunctivitis. Right, so this is their set of symptoms. And then to have the disease confirmed, they have symptoms plus antibodies or RNA from the test, blood test. So when they went and went to through the medical records, they found 185 suspected cases based on symptoms. So why do you think this is so much lower than the 414 just sort of randomly selected people? So if you just go out to randomly selected people in this population, you get 75% have been infected. So why are you only getting 185 here?
Only people with more severe symptoms who are going to the hospital or the medical centers.
Right. So probably what's happening here is that you're getting the most severe cases. The people who are showing up at the medical centers are the people who are the most severe. So of their 185 cases, they found 49 that were confirmed based on RNA or strong antibody evidence, right? So here's where the tests get a little shaky, right? So they have 59 probable Zika, right? So there's some antibody evidence, but it's not very strong, right? So despite the fact that blood tests give you an objective answer, it's not always a conclusive answer. Right? And for those of you who are clinicians, I'm sure you're well aware of that. And then 72 suspected Zika, right? So these are people who they didn't have any tests on, but they had the symptoms, and 5 who tested negative, but who met this case definition. And this is the sort of thing that you're going to see with even a very severe outbreak. Things are never clean, right? So a number of years ago, when there was the anthrax through the mail, they were doing this extensive case detection, really strong case finding, and they found a case of pulmonary anthrax in Connecticut, among in a woman who, had not gotten any of these letters, had no reason to be targeted. So who knows where that came from, but it was probably a real case, and it's probably the sort of thing that is sort of happening at a very low level in the population, but once you start looking, you start seeing these things. So it's not like, even though the vast majority of the pulmonary anthrax cases that happened during that time, were because of a terrorist attack or a biological attack, there are some that are sort of, it's never sort of a neat picture. So these answer questions about how many and who. They can sometimes give you hints about why, but they're not really designed to talk about why, right? This is really just, what is happening in this population? We also, sort of our next sort of most complicated study design is called an ecological study. And so the ecological studies are looking at the correlation between the rates of disease and the rates of, or the degree of the exposure. And both the exposure and the outcome are measured at a population level, right? So you're not necessarily going in and looking at individual people and seeing were they exposed or not and did they have your disease of interest. You're looking at, you're comparing populations or subpopulations to each other. So in cardiovascular disease, this sort of kicked off a lot of the nutritional cardiovascular studies. This is called the 7-country study. And in this study, they went to several different populations. Some populations have multiple subpopulations, which is why you have more than 7 dots here. And they looked at, on the y-axis, you've got cardiovascular CHD deaths per 100. And on the x-axis, you've got, let's see, I'm still getting used to this pointer, apologies. You've got calories, percent of calories that are saturated fat. Okay? So you see this really pretty strong correlation. So correlation is the maximum value of correlation is 1. And what you see is a correlation of 0.84. So that's pretty strong between percent of calories consumed, or percent of calories from saturated fat and CHD deaths. And you can see that saturated fat is ranging from about 5% of intake in Corfu to 25% or more in Eastern Finland. So in Eastern Finland at that time, it was largely logging. That's how people made their living. And so people were eating, first of all, a lot. And second of all, they would eat buttered cheese sandwiches. So that was sort of the standard thing that people would eat for their lunch while they were out in the woods. So very high saturated fat intake, very high CHD death rates. So I have since, when I started looking for this graph, found that there's a lot of sort of conspiracy theories about this, but even when the investigators were doing this, they knew that there were some issues with this, right? So they're looking, they don't know, even within populations, there's variation on how much saturated fat people are consuming. And we don't really know that the people who are really consuming the most saturated fat are the ones who are having the heart disease deaths. The other thing about this is that to get at percent calories from saturated fat, what they're really looking at is USDA type data. So they're looking at how much, or agriculture data, right? So how much food is being produced and how much is being exported, and you subtract that out and you wind up with sort of local intake. But you try and do what you can, but every once in a while you wind up having to throw away food, or there's some wastage, other things can happen there. The great thing about ecological studies is that they're often something you can do with existing data, right? So you can go to, places like the CDC. CDC Wonder is this website where you can download all kinds of statistics, like CHD death rates, all sorts of vital statistics, and you can download them by the state or county level, and then you can get, census data, right? So that data is out there, and you can use those types of data to do these kinds of ecological studies. You don't necessarily have to go out and collect new data, so that's one of the things that's really appealing about them.
I have a question. Thank you. One thing I was thinking about when it comes to population studies, even though we're looking at that graph, you cannot control for other behaviors that take place within the population, things that they may do that may either mediate or moderate the effect of the cardiovascular heart disease.
Absolutely, right. So comment being that we don't know about all the other stuff that might go along with consuming a large percentage of your calories from saturated fat. And in fact, one of my grad school professors had taken this graph and had same CHD death rates and had graphed bathtubs on the x-axis, bathtubs, how many bathtubs were in the population. And you don't get this like really high rate from Eastern Finland, but the correlation's like 0.7, right? So it's still, you see pretty much the same. So to what extent is this sort of a development wealth kind of issue as opposed to specifically being CHD? Yeah, that is absolutely a major issue with these kinds of ecological studies.
But to cater to that, for example, we take a lot of these epidemiological studies and then do hypothesis-driven testing where we would take mice and we would feed them on a more high-calorie diet and then see how many develop cardiovascular diseases. And that's kind of, since we cannot really do the experiment in humans, doing the mice experiments or rodent experiments will cater to that and provide much more evidence to that. And like I think by this time it's quite evident that increased caloric intake leads to increased death in rodent population as well.
Absolutely, right. So I'm an epidemiologist. I'm a believer in observational data, but there are very few times where I would, based entirely on observational data, would I go and say this is a causal effect, right? So I think we need to do other studies like the rodent studies that you mentioned. I'm always a little leery because rodent metabolism is not necessarily human metabolism, so if we see different answers, but yes, absolutely. We learn a lot about metabolism from these very controlled studies in non-human model species. You can actually do the experiment in people. And there have been experiments done in people. So there are several clinical trials, mostly in very high-risk people because that's in order to, 10,000 people to do a trial, you need kind of a high-risk population, but there have been studies showing that switching out monounsaturated fats for saturated fats does actually reduce the risk of heart disease. So yeah, certainly you want to do follow-up testing. You don't want to take this and run with it. You want to, in terms of population health, right? You want to take this and see what else is out there that might support or refute this kind of finding. So one of the things specific to the points that you raised are sort of general to observational studies. One specific to ecological studies is what I mentioned, where we've got variation in within populations, and this is called the ecological fallacy, where we don't really know that the people sort of in Eastern Finland who are having the heart attacks are the ones who are eating their butter and cheese sandwiches every day. So cross-sectional study is the next sort of study design, and that does allow you to take into account some of the factors that you mentioned about what else might be going along with your exposure. So because here we're looking at individuals, right? So rather than looking at populations, we're looking at individual people, and we're looking at, do they have the disease at that time, and what was their exposure like at that time? So this is an example of a study that I did a couple years ago. So we're looking at unrecognized heart attacks, unrecognized MIs, and about 20% of MIs are not clinically recognized, which is a high number, but there's been a bunch of different types of studies, and then this is pretty consistent. So what we did was we took a population who told us that they had never had heart disease, and we also excluded people who told us that they had had stents or some other sort of coronary procedure, just to be sure. And then we looked to see how many of these people had Q waves on their ECGs, and with a reading to suppress other reasons why there might be Q waves other than MI. So what we see here is these are odds ratios, right? So odds ratios are, so odds are these funny measures. It's the number of yeses over the number of nos. So it's sort of like a risk, but not quite. And then you take the ratio of those. So they're a little bit, it's a little hard to get your mind around. But basically, anything that is, because these are ratio measures, 1 means no association. Anything that's above 1 means that is associated with more of your outcome. And anything that's below 1 means it's associated with less of your outcome. And then we've got confidence intervals, and those just sort of give us a sense of what the range might be, right? Because we don't have an infinite number of people. We don't. So the odds ratio is sort of our best guess, and then the confidence interval kind of gives you a range. David Redden, I think, is going to come next week, and is probably going to give you a much more mathematical explanation of what that means.
What does it mean by the age 10 years there? Age.
Age 10 years, so that's for every 10 years older age, that is a 38% higher odds of having unrecognized MI, right? So, so you can scale these things, right? So I could have looked at 1 year, could have looked at 1 day, right? But 10 years is sort of a good chunk to look at. So people who were current smokers compared to non-smokers, they had a 60% higher odds. Self-reported diabetes, there was a 25% higher odds of having unrecognized MI. Hypertension was 56% higher odds. And blood pressure, and again, this is for a 10 millimeter of mercury higher blood pressure, had an 8% higher odds, right? So all of these things are risk factors for cardiovascular disease. It's not super surprising that they were associated with this unrecognized form of cardiovascular disease. And so we could do this because it's relatively simple logistically, right? So what I had done, the REGARD study, is this big population-based study based here at UAB. It's about 30,000 people from across the US. They've been followed up for a long time. They had an ECG at baseline, right? So they had an ECG, and so that data was sort of sitting there and I could analyze it. Since then, right, so since I did this study probably, it's been a while, probably 5 or 6 years ago, we've gone back and we've done repeat ECGs for everyone that we could find who agreed to participate and who was still living. And it was about 10 years after the first one. So then we can look at incident disease. But right now we're just looking at prevalent here. I couldn't have done the incident disease study when I first started here, right, because this was one of the first papers I worked on when I came to UAB, because it hadn't been done yet, right? So I would still have to wait a couple more years. And the prevalence of that disease is related to both the incidence, right, so how often does this happen, and the duration, right? So, and you've got this issue, not in my case so much, but disease may change exposure. And I'll give you another example in a second after I go through mine, right? So how did we get people in the REGARD study who had an unrecognized MI, right? So first they had to have an MI that caused a Q wave. Not all MIs cause Q waves. They had to have somehow that MI had to go unrecognized, right? So either the person didn't feel pain, felt some pain and kind of wrote it off and didn't seek medical attention, sought medical attention and didn't get diagnosed, or sought medical attention, got diagnosed, and then somehow did not understand their diagnosis. So when we came some point in the future and said, have you ever had heart disease, they said no. All of those things are possible. They then had to survive not only their initial MI, but the follow-up, however long, and then say, oh yeah, I'll join your study. And that Q wave had to persist, right? So Q waves can resolve over time. So all of those things had to happen, and there are sort of different factors can affect every one of these steps in order to get to my unrecognized MI definition, right? So that's, you know, so all of these things are talking about both the incidence and the duration of the disease, and so those kind of get mushed together when you're doing a prevalence study. So for an example of disease-changing exposure, when I was in grad school, one of my friends was, her area of focus was on lupus. And there were just a raft of studies that were coming out. And they were saying, look, people with lupus have much lower vitamin D than people without lupus. Low vitamin D is a risk factor for lupus. What's the problem there?
They may not be active.
They might not be active, right? So people with lupus may be less active, and people get vitamin D largely from the sun or from sun exposure.
Could it be that low vitamin D was becoming like a new topic and people were discovering that lots of people had low vitamin D?
Yes, certainly it was the case that vitamin D was a big hot topic and everyone was doing all kinds of vitamin D tests.
Both of those things are also more prevalent in African American populations.
Right, so you've got African American populations having higher risk of lupus, and then also because are having lower vitamin D in response to sun. Yeah.
Also in response to milk, if they're lactose intolerant and can't get vitamin D fortified milk.
The big one is that people with lupus are sun sensitive, right? So lupus can cause major sun sensitivity and cause really bad rashes if people go out in the sun. So, in this case, actually having lupus is going to reduce your sun exposure, right? Because people are going to try and avoid these rashes. I mean, all those other things are certainly, but in my particular example was that, the fact of having lupus is going to lead to lower vitamin D due to sun exposure. So, yeah. So yes, my friend would rail against these studies every single time they come out, and it was like one a week at that point. But, I think there are ways, and we'll talk about other sorts of study designs where you could get at some of these other potential, or could rule out some of these other potential explanations. Okay, so cohort study. So this is one of the ones where you could actually rule that out, because you could identify a population who is at risk of the disease but does not yet have it, right? So if you had a population of people before they got lupus, right, and then you could test how much vitamin D they had, and then follow people up to see whether or not they developed lupus over time, and that would give you a better sense of whether low vitamin D truly was a risk factor for lupus or not. So, example here, so alcohol and MI. So there were a little more than 38,000 men who completed questionnaires about drinking habits in 1986. And then every 2 years for 12 years thereafter, participants were sent questionnaires. They're asked if they had had a heart attack, and if they didn't return their questionnaire, the investigators would go out and start looking for death certificates to see if people had died of cardiovascular disease. These kinds of studies have tremendous logistical sorts of components to them, so that's not my area of expertise, but I work with some people who are really good at making sure that they can follow people for very long periods of time. So it's really an art. And then they were looking at rates of heart disease compared by alcohol drinking and by types of alcoholic beverages consumed. So here, are you guys familiar with looking at graphs like this? Got some yeses, some no's. Okay, so this is relative risk. So this is, again, a ratio measure. So 1 is our no association value, right? And so, let's see, try and use this. Okay, so we've got 1 being no association, right? The dots are in this case, they're hazard ratios, but sort of these ratio measures. Compared to no alcohol. Right? And each of the different symbols is a different type of alcoholic beverage, right? So one of the things that you'll hear in the popular literature all the time is that red wine is good for you, right? Better for you than anything else. Here, right, pretty much any kind of alcohol drinking is associated with a lower risk of MI. Doesn't matter whether it's red wine, white wine, beer, liquor, pretty much anything. So which suggests that maybe it's the ethanol and not the other stuff in the red wine. You can see this association goes up to about 50 plus grams of alcohol per day, so grams of ethanol per day. So that's like 3 to 5 drinks per day, right? So at that point, you probably are having other issues. You know, there's cancer risks involved as well as the risk of accidents and other things. But you do see this fairly consistent inverse association. So to the earlier point of what else are they doing? So, you know, in the U.S., particularly red wine drinking is associated, or wine drinking in general is associated with, you know, higher socioeconomic status, you know, sort of better health behaviors, more exercise, things like that. You know, there's more intake of, you know, fruits and vegetables. So all those things they've statistically adjusted for to the best of their ability. It's not perfect, but that the investigators have tried to take that part out of their association. Thoughts, questions about this? So this is pretty consistently found. Yeah?
I'm trying hard not to tell. Can you, the red wine with the increase in the relative risk?
Yeah.
It's like 1.5.
Right. So why is it 1.5? That's a good question. You know, my guess, so all of these, that's where the confidence bounds really come in handy thinking about this. So, you know, there's always going to be some sort of noise. And you can see that this confidence bound is really big.
Yes, it is.
So it suggests that there aren't that many people in this category, right? So this is people who drink essentially like 5 glasses of wine per week. So this is saying like a little less than 1 per day. And for whatever reason, probably there just aren't that many people. People are probably either drinking 1 per day or like 1 a week. So that they would be in these other categories. So yeah, there's always going to be sort of things like lines, the estimates that don't quite add up or don't quite fall in line, I guess is sort of what I'm thinking.
So the confidence interval is going to be pretty wide. It can be like something off the charts, right?
Yeah, I mean, so this one is going from, I mean, I could have made this figure a little bit clearer, but this as this confidence bound is going from like 0.7 or 0.8 to 2, right? So that's a wide. That's wide, and the wider your confidence bound, the less you can trust the exact number, right? So the tighter your confidence bound, the more certain you are about it's that number and not something, you know, on either side.
What did you drink in my red wine?
Yep, I mean, I think I wouldn't not drink red wine based on this. I wouldn't also necessarily go out, and this is still something that's a big issue, you know, big discussion point. So this author actually has a clinical trial looking at alcohol drinking, so with cardiovascular disease endpoints. It took him, this was like, you know, years ago that he wrote this paper, and he's finally gotten to the point where they have gotten IRB permission, and they've got this clinical trial running, a placebo-controlled trial, sort of placebo-controlled. Yeah, unfortunately, they wanted to do red wine and de-alcoholized red wine. They wound up with grain alcohol dissolved in either Crystal Light or just Crystal Light. And they did manage to get people to sign up for this trial. So one of the benefits of doing this kind of cohort study is that you have temporal order, right? So here you know that the exposure happened before the disease, right? So unlike the sort of lupus and vitamin D example, right, we know that people were drinking alcohol before they had their heart attack, right? We're looking at incident disease, right, so we don't have to worry about this prevalence issue that takes into account the incidence and the duration. The downside, right, is that it takes a long time and a follow-up of a lot of people. That means expense, right, and you're not going to get your paper out for many, many years. So the more common the disease, the sort of easier it is to set up a study like this, because you don't need that many people. The rarer the disease, the more people, the longer follow-up time you're going to need, right? So heart attacks are relatively common. We could do this, you know, if we're looking at, say, glioblastoma, right? That's a fairly rare disease. So in order to do a study like this, right, so this was 38,000 people, you'd probably need 4 or 5, 10 times as many people, right? So that is a big study. So you might want to do a different type of study design. So case control studies are one of the examples of a study that we do when we have a disease that's rare, right? So we can't necessarily go out and capture enough people who don't have disease and then follow them up and see enough cases to really be able to make any kind of determination. So with a case control study, you identify the cases, right? So you go out and you say, okay, here are the cases of the disease. And then you find a control group who's in some ways comparable, who do not have the disease, and then you compare their exposure history. So there was a case control study of persistent pulmonary hypertension of the newborn, right? So I don't know much about this field, so if anybody would like to correct me, please do. But this is basically something that happens when there's a problem with switching between fetal and non-fetal circulation. And so there's there's too much blood flow essentially going through the pulmonary system. And it can be very severe. It's a major disease. Luckily, it's pretty rare, right? So this study had registries from, I think it was 7 different states. So it was capturing over the course of a number of years, several different states, looking, screening all of the births, and they only found, luckily, 377 cases. So they identified the cases, and they did a long series of interviews, and then they also identified infants and mothers without this condition, and did a series of interviews of those mothers and medical record reviews and other things. So here is where very careful interviewing comes in handy, right? So if you go to someone who has a child with a major health problem, and you ask them, what did you do during your pregnancy, right? You've got to be really careful to make sure that you're not sort of asking leading questions, right? Because people are really, they're really looking for answers as to what happened here, right? And so you might get very different answers and very different recall and ways that people are answering the questions if they have, a newborn who's healthy and a newborn who's, in the NICU. So this study has been going on. It looks at a lot of different adverse fetal outcomes or newborn outcomes, and so they have this down to an art, right? So they are asking about SSRIs. They're asking about a whole bunch of different things as well, right? So there's a lot of sort of essentially negative controls in this study. What they see, right? So these are self-reported SSRI use. Again, these are odds ratio charts. You can see that this is their reference group, right? So the never, and that's why you've got no confidence bounds on that, because that's always going to be 1. You don't really see an association with SSRI use and PPHN before 20 weeks. What you see is potentially after 20 weeks there might be an association. Right? So, or there is an association in this study. There have been a number of follow-on studies, and they've been kind of equivocal, but the fact that you see it after 20 weeks is sort of suggests that maybe this is real, because that's sort of the biological time point at which you would expect the drugs to have some sort of effect. Okay. And so if you were trying to do this study, if you were going to UAB, right, and recruiting all the women who are giving birth at UAB, you would be doing that for a very long time in order to try and find enough cases to study that, right? So you wouldn't necessarily set this up as a cohort study. This is the kind of thing that really is limited to this kind of case control study where you're asking people after the event has already occurred. So this is really efficient when the outcome is rare, but you have to be really careful because the exposure is also often measured after the outcome happened, and the outcome may change either the exposure itself or how people report the exposure.
How does the outcome change the exposure?
So that would be if we were, say, looking at say, blood oxygenation in these infants, right? The fact that they have PPHN would potentially impact their blood oxygenation. Does that make sense? Okay. Yeah, in this case, the outcome isn't going to, it depends on what your exposure is. In this case, your outcome isn't going to change your exposure, but it could very well change how mothers are reporting their exposure. So let's talk a little bit about correlation and causation, and then we can take a break. Okay, so here, right, correlation does not equal causation. You hear this all the time. So why does correlation not equal causation? So, you know, we've got biases in our studies, right? So there are other things that are going on, right? We can't just assume that our one exposure is that we're interested in is the only thing that are different between people who are exposed or not exposed. There are, well, depending on how you define them, there are an infinite number of biases that you could that could come in. The big ones that I tend to think about, because the different training programs in epidemiology are either sort of lumpers or splitters, and so I came from a lumper. So we tend to not name and sort of specify each different type of bias, but confounding is one, right? So confounding happens when you've got where your exposure is associated with other things that could affect risk. Measurement error, so that's an issue where your test isn't right? Or you've got or people aren't reporting accurately. And then selection bias is one where you've somehow picked people who are different in ways that are sort of hard to get your arms around. So a lot of what we do as epidemiologists is trying to figure out how to reduce and mitigate these biases through design and then through statistical analysis. So confounding happens when people who are exposed are different than those who aren't in ways that aren't directly related to your exposure, right? So the risk, the other way of describing this is that the underlying risk is different in the exposed and unexposed groups. So, there's been a lot of studies looking at race, ethnicity, and obesity. In the U.S., this isn't a biological relationship, but in the U.S., people who are non-white tend to be younger than people who are white, and that's just a demographic sort of thing. So if you're looking at different groups, right, and you're looking at obesity, you know that age is related to obesity. Some proportion of the association between race, ethnicity, and obesity is due to age. Right? So this is sort of a classic confounding situation. So our solution, we can control for age. And there's a bunch of different tools that we use to do this. We can measure age, we can control for it. Not a big deal, right? On the other hand, if we're looking at, say, fruit intake and obesity, right? So fruit intake is our exposure of interest. We want to know, is that associated with obesity? You've got this sort of propensity to be healthy, right? So people who are health conscious eat more fruit, and people who are health conscious are less likely to be obese. And how do you measure health consciousness? Right? So we've got some part of this association between fruit intake and obesity is due to being healthy. And we're a little stuck, right? So age, we can get our arms around, we can measure that. We can get at some of this propensity to be healthy, right? We can measure things like how much physical activity do you do? We can measure, like, do you get your flu shot, right? So there's things that we can get that are sort of proxies for this, and we can do our best, but there's probably some amount of this that we're not ever really able to measure and adjust for in a satisfactory way. Now there's things that are sort of have this kind of thing, this kind of structure, but are not confounding, right? So if we're looking at obesity and myocardial infarction, right, one of the ways that obesity can cause myocardial infarction is through diabetes, right? So diabetes is part of the causal pathway. And in this case, diabetes is not a confounder, right? Diabetes would be a mediator. So you need to, there are some like automated ways that people will sometimes use to try and figure out what's a confounder. You need to figure out like which direction are you going, right? And because things, you know, in this case, diabetes is going to be associated with your exposure and your outcome, but it's still not a confounder because it's in that causal pathway. Okay, so take a break. How long a break do you normally take?
Can I ask you a question?
Yep.
So then,
I know observational studies are not to replace randomized controlled trial, but there are ways to control confoundings, and propensity scores and things like that have been discussed. What is your opinion, or how would you use propensity score matching and things like that to, what is a good type of study to introduce or incorporate propensity scores in cohort studies?
Right, so...
Maybe you could just define what that is before you go on.
Okay, yes, so the question was about how would you use propensity scores? Would you use propensity scores? So there are a bunch of different ways to control for confounding. So, you know, there's multivariable models, right? So you're essentially adjusting. You put the, you know, the variable in your model. And what that does is it sort of says conditional on, you know, conditional on age. What's the association? A propensity score is a score where if you have a bunch of different confounders, right, and usually you do have more than one, you can sort of come up with some sort of composite single measure of those different confounders. And then you could either adjust for it as if you were, you know, adjusting for age, but now you're adjusting for your propensity score. You can match on it, right? So people on average will have the same sort of distribution of their confounders in their exposed groups and your unexposed groups. You can do weighting. There's a bunch of different sorts of techniques. Propensity scores are one of those things that sort of hit the field and people kind of fell in love with in ways that are, in my opinion, maybe they get overused or are over-relied upon. If you match on a propensity score, your table 1, right, so your sort of descriptive table looks like a clinical trial, right? It looks like you've got the same average age, you've got the same distribution of gender, you've got the same distribution of, you know, all your comorbidities. The truth is, though, that it's not a randomized trial, right? Because a randomized trial is going to balance on everything measured and unmeasured on average, right? So in a big enough trial, if you're assigning exposure at random, not only is it the things that you've measured that are the same, it's the things that you haven't measured. Propensity scores don't take into account the things you haven't measured. So when I would use a propensity score is when I have essentially too many confounders to put in my model, because there's a limit to the number of things that you can adjust for in a model. And so if I've got a ton of stuff that I want to adjust for and I don't have a big enough study to put them all in my model, I would use a propensity score. In that situation, I would also use a propensity score when you've got some people who are sort of always going to get treated and some people who are never going to get treated, and then a group in the middle, right, who sometimes would get treated. The propensity score, if you match on it, will essentially only give you that middle group. And so that, if that's a group of interest, that would be another time I would use them. Does that make sense? Other questions? Okay, 5 minutes?
Great,
Sounds good.
take a 5-minute break, thanks. Yeah, so I think the scanner wasn't set up properly for some of you coming in, so it should be working now. If you can scan yourself in, that'd be great.
Trying things to talking to somebody who don't really have a name yet, and my dad some people on the top of your head has done some really well. Yeah. I think that's Equal person. And she had this experiment because I knew like there's not working school. I'll get back anyway. Everything so that's just whatever. But trying to locate someone April person, she's done probably not a lot of epidemiology, but she's expert in diabetes. Don't know what she specifically used any, but yeah. The other things I think we want to do is Walter Willett has a book called Nutritional Epidemiology that talks about how to get those different types of nutritional measures. We'll have time to and then when we go, it really depends
Maybe it's my bad.
You can certainly use it. It really depends essentially on how many subscribers you have. I got a letter. So then, if you have an email with a letter, why you don't know what it is. So then, no, just let proceed. I just have a couple of things. Instead of adjusting as 81 items, it would give you a score and adjustments. Oh, just for the propensity score? Yeah, the propensity score, you can just sort of collapse all these variables into one. Yeah. So then, so then, there's different ways of doing it. You could have that and just figure out, what your propensity score, and then that's the. That's your super easy. So you would have your outcomes on that side, your model, like your y-axis, and then you have your exposure, and then your or if you have small samples, that can make you really you pierce yours and it's like I'm cleaning up Did everybody get signed in? No, you don't necessarily have to have tumors, but it's
As long as you have exposure and not following just the cross-section.
Yeah, yeah. I mean, if you're sort of looking at if you're saying, okay, does this group, what's the outcome in this group? You need to be in that condition. You're saying, yeah. So, you have to say, okay, this is what
That's just too much. Yeah, something popped up on it. I think I'm gonna go back to every time I fit English, it's written. If it actually tripped my but I just want to make sure.
Okay.
But right now, it's just descriptive. Because, what? Risk factor.
So, it's not very cerebral. But sometimes it's an exposure, right? So sometimes what causes physical activity can be right? And then in exposure, a lot of times what that do is something I'm trying to adjust for. And then one of my colleagues in epidemiology her work is all about getting people physically active. Yes. So in that case, she's doing very often.
Yeah, I use it as my outcome, my secondary data analysis. I'm learning just to track models to the brain, just to we have the see the impact and sometimes it looks shocking. And it's, yeah. That's good. That's what I'll probably do for the next reference study. Look at more power.
Oh, great. Yeah, really good for
Just using the government, when the House went back and asked for John's guidance. I'm biased.
We're having, we hope, a very temporary fire alarm. We'll be back soon, we hope.
How are you doing?
Yeah, and then it's only adults. It's this, so it's not like you'll start to change it. You'll realize it. Oh man, I just want to show you some like because you'll like we put it out if y'all had it, like because
Okay, we're getting ready to reconvene in just about 2 minutes.
they asked basically if you wanted to hear about how before Thanks everybody for sticking around through the fire drill. Unexpected longer break. Okay, so back to our regularly scheduled program. The next thing I'm going to talk about is developing a testable hypothesis. So one of the things that my students tend to do, and you guys are probably a little more focused than some of our first-year graduate students, but thinking about coming up with questions that are career-long research plans, as opposed to things that you could actually do a study and test. So, does diet affect heart failure? This is what I did for my postdoc, and for some time after my postdoc. But this isn't really, that's not really a research question, right? That's not a testable hypothesis, because we need to know which aspects of diet, right? We're talking about specific foods and nutrients. We're talking about diet patterns, deficiencies, overloads. How are we interested in? Like, what kinds of effects we're looking for? Prevent slow progression, prevent mortality in people who already have heart failure, reduce the symptoms, improve quality of life. All of these are potential outcomes that you could look at. The other question is in who, right? Are we talking about older people? Are we talking about younger people, women, people with diabetes, mice, right? So all of these are things that we need to narrow down in order to have a hypothesis that's actually testable in any sort of reasonable period of time. So thinking about what makes for a good research question, there are these sort of two sets of criteria, two guidelines that people talk about. So for developing your idea, there's what's called the FINER criteria, and then for framing, there's what's called the PICO approach, and these are both acronyms. And this paper down here, these authors didn't come up with these, but they have a really nice explanation of sort of how to go through thinking about these. So FINER stands for feasible, interesting, novel, ethical, and relevant. Okay. So are these absolute sorts of criteria? No, right? So, what is feasible for me is not the same thing that's feasible for my master's student, and what's feasible for me is not what's feasible for, say, the Howards who run the Regard study and have amassed this enormous machine that is able to follow and adjudicate events for 30,000 people spread out across the 48 continental U.S. states, right? So I don't have, so that's not feasible for me, but so thinking about sort of where you are and what your resources are really determines what's feasible. Interesting, right? So that's somewhat in the eye of the beholder. But when you're thinking about what are you working on, right? You don't want to do just a Me Too study, right? So if you're looking at a question that's already been examined, how is your study going to add, right? If it's just sort of another study in the same line of research and everybody else has found similar results, right? You don't necessarily want to do that. But if you're saying, okay, this is a very different population. I have seen associations, in, say, colorectal cancer, but this may or may not be the same in people with thyroid cancer, right? So that's something where it might be more interesting. And also that gets into sort of the novelty, right? So you don't want to do the same study without adding something. Ethical, right? So we want to treat our participants with respect and respect their both their safety and then also their the time and effort they put into participation. So one of the things that was sort of stressed and emphasized and X'd out, right? We don't have subjects, we have participants, or we have patients, depending on whether if they're sort of general population or participants, if they are a particular population is recruited because they have a particular condition, then they might be patients, right? But we don't have subjects. These are people who have dedicated their time and effort to help us with our research. Ethical also, some people have, it's a balance, right? It's a judgment call. So I was reading a study that was very interesting and had really important data, but they had people with heart disease doing stress ECGs while breathing in diesel exhaust. And I'm reading this thinking, really? They got that through the IRB? There were no major harms, but that's a judgment call. And I probably, if I was sitting on IRB, I might say, don't do that. But it was important, and it really stressed. It was one of the things that stressed, that we need to make sure that we get the pollution levels down. And then relevant. So I think, how does this affect clinical care? How does this affect public health? How does this affect our general knowledge? If it isn't going to do one of those things, it may not be worthwhile. PICO is really more about how you frame your hypothesis, right? So you want to specify your patient population of interest. And so this is really set up more for sort of an intervention clinical study. So, but who's your patient or who's your population of interest? What's your intervention or issue? I would probably have exposure, but then you wouldn't have this nice acronym. What's your comparator group, right? Are you comparing, a new therapy versus standard of care? Are you comparing a new therapy versus nothing? Are you, sort of what kind of comparison are you making here? Because it's very important to specify that, right? For a lot of the dietary exposures, right, it's not that you don't have any people who don't eat, right? You've got people who are eating more or less of some set of nutrients or some set of foods. What is your outcome, right? How are you going to define your outcome? And what is your time frame? So why is time important? So this is a little bit of a silly example, but is rabies associated with a higher risk of death?
Yeah.
So yes, right? That's sort of the obvious answer. And my answer would be it depends, right? So if you're looking at, this is your cumulative incidence. So here's your risk of death, right, over time. And people in red are the people with rabies, and the people in blue have no rabies, right? In the year after infection, clearly there's a huge difference in risk of mortality in people who are infected and not, right? But if you're looking 100 years out, there's nobody who's still going to be alive, right? 100% of the people who were infected with rabies will be dead, and 100% of people who are not infected with rabies will be dead. Right? So that's, like I said, this is an extreme and sort of silly example, but, if you're thinking about, in cancer we talk about 5-year survival, right? We talk about 5-year survival because, 20, 30, 40 years out, right? You've got all of these other reasons why people are dying. So yeah, this picture shows, if you have pictures like this sort of shows the time in it, but the risk measure itself, just sort of that proportion, how many people, what percentage of people have died, does not necessarily, very far out, does not necessarily capture that. So that's why we always want our time. So here's my better question, right? So we're looking at fatty fish intake associated with hospitalization for or death from heart failure among women. To get a little more specific, what we're talking about when we're talking about fatty fish is salmon, herring, and mackerel. This is Sweden, so people do eat herring and mackerel. In the US, you probably wouldn't, very few people eat herring or mackerel, so that's not really so much of an issue. We've got about 9 years of follow-up, women who are middle-aged and older. So 2 counties in central Sweden, and we're looking at first heart failure event, which we're defining as a heart failure hospitalization or a death from coded for heart failure. When we did this, we see that there looks like maybe there's an inverse association between fatty fish intake and incident heart failure. That maybe there's a little uptick at the end. But again, you've got these, when you're looking at the confidence intervals, that gives you sort of a sense of where that might be. The other thing is that central Sweden is a pretty homogeneous place. Almost everybody is eating salmon, herring, or so almost everyone's eating salmon or herring once per week. And the people who are eating salmon or herring more than 3 or more times per week. Okay, so pickled herring is a bar food in Sweden, and so people are getting this huge sodium load, and they're drinking a lot. So and so we tried to adjust for some of that stuff, but yeah, I'm a little concerned about the people way out at the end. Okay. So, let's see if we have time for this. Okay. So any questions here? Yes?
I have a question. You set your never group as your, your 1. Mm-hmm. You talked about virtually everyone eats 1 serving per week. So how does that impact your data if you choose a point that's not necessarily reflective of your population's goals? How does that, I guess, change that graph of what we're looking at?
Right. So that's a very good question. So it wasn't that nobody. It was about 15% of people never ate fatty fish. But that's a pretty small group there. What that will do is it actually makes all the other confidence intervals wider because we have a small group in our referent group. So if I was to do the study again, sort of as you suggest, I might pick sort of the normal behavior as my referent group. That would make my confidence intervals a bit tighter. But then I might do that. But the reason I did it this way was because there were a couple other studies that have looked at this, and this is sort of the same way. So this increased comparability. So yeah, that's a good point. It'll make your confidence intervals wider a lot of time, and so it would be a rational choice to pick sort of the normal thing to do. Sort of to get to going back to sort of the finer criteria, the reason I did this, even though other people had already done it, was because people had done it in the U.S. And in the U.S., eating fatty fish is a socioeconomic indicator, right? People generally, higher SES people are eating salmon, right? And so the confounding, it's hard to sort of pull out that socioeconomic status versus sort of dietary exposure. In Sweden, everybody eats, or pretty much everyone eats fish, so it's less tied to that kind of social exposure. Other questions? Okay, so if you were to say come to one of the CCTS clinics, we sort of walk you through, maybe not exactly in PICO, but walk you through, okay, what is your outcome? So does anyone want to volunteer to be the guinea pig for this? Anyone have a study they're thinking about designing?
Health-related quality of life.
So health-related quality of your life is your outcome. Okay, sounds good. What is your exposure that you're looking at?
What is the exposure?
Yeah, so if health-related quality of life is sort of the thing that you are going to measure, is your outcome you're measuring, what exposure are you looking at? What do you want to know affects quality of life?
Physical activity.
Okay, so the question is, does physical activity improve health-related quality of life? So we're saying physical activity versus none, or a program versus no program?
Program versus usual standard of care. You have a BMI of 40 and you're chronically ill and old. No exercise. Don't say anything to them. So the usual standard of care, they still receive the same care from the VA, and that's where my program comes in.
Okay, so we're looking at some sort of program, physical activity program versus sort of standard of care, which is probably for almost everybody nothing. No physical activity and no advice for physical activity, both. Right? And so you said veterans were your?
Older veterans, 65 and up, with 3 or more chronic health conditions.
Okay, that is a very good specific patient population. If you were to come to me as like the CCTS Statistics Epidemiology Research Design, you get a gold star for that, right? So because who are you talking about, right? And that's a good specific population. And what kind of time frame are you looking at?
Right now, I'm looking at 8 weeks.
8 weeks. Okay, so why 8 weeks?
It has to do with development of a habit and also funding and practicality of the grant, given the time, the amount of money, that sort of thing.
Okay.
The development of a habit, really, and then funding.
So, okay, so that's, funding and how are you actually going to carry this off, always important. And so, always a key part of thinking about, what would be your ideal study, and that's always the question that we ask our epidemiology PhD students at their defense, like, okay, this is what you did. What would you have done if you had all the time and money in the world? Versus, what can you actually do with the resources you have? And then also, but that also has to be related to something that, is sort of real, right? So that it might take 8 weeks to develop the habit to sort of have that impact on health-related quality of life. So what would be, so say that if you're not doing a trial, right, what are the important confounders? If you're just sort of going and, if you're not randomizing people, you're just, collecting people and allowing them to choose.
Okay, the severity of their chronic illnesses. Some may be newly diagnosed with diabetes. Some may be exposed to diabetes as a result of Agent Orange when they were in Vietnam 40 years ago or whatever. And some may just been developed with it. Some may have hypertension and have experienced a known stroke. Just the variation in the disease status, health status would be one thing. And age, mobility, it's a whole lot of confounders. Right. Frailty, whether they're walking assisted or unassisted, it's a lot. They're sick.
So the confounders that are going to be the most important confounders in your studies are the ones that are going to be strongly associated with your disease or your outcome of interest and strongly associated with your exposure, right? So for example, mobility in your study, right? So mobility is going to be, we know that people with low mobility often have lower quality of life, right? So that's a known association. And, it makes sense that people with low mobility might not sign up for an exercise program, right? And so those are the things that are, the things that are most strongly associated with your exposure and your outcome, right? So as sort of an aside, knowing which confounders and sort of knowing, because you have to know something about the world, right? You have to know something about cause and effect in your question in order to really set up your study properly and to run the right kinds of statistics. Because of that, that's why epidemiologists rarely work by themselves, right? So, I have some expertise, some knowledge about heart failure because that's what I've studied most. But I'm working on a project right now, a big project in HIV. Really know very little about HIV. So, a lot of what I do is I say, okay, so how, I'm asking the people, so the researchers and the clinicians who I'm collaborating with, okay, how is this working? Which things are most important here, right? So that I can help set up a study that actually makes sense. Because you can go pretty far wrong if you don't know about your disease condition. Okay, so that's those are the sorts of questions that you would, get asked, if you were to come to the BIRD kind of consult, which is the Biostats Epi Research Design. And then thinking about which study design, right? So how frequent is the outcome? So that's less of a question where you're talking about health-related quality of life, where that's a continuous measure. So sort of there the question is more sort of what's the distribution of that measure, right? So is everybody saying, oh yeah, my health-related quality of life is great, right? That's a little hard to analyze. But if you've got some range, right, then you can actually do that study. If you're talking about, if you had your physical activity study and you were saying, okay, I'm going to see, how many mortality, right? I would tell you, you're not going to be able to study mortality as your outcome in an 8-week study, right? You just, it's not a common enough outcome in that patient population. That you'd either have to lengthen it or you'd probably want to lengthen it, actually. So if you were thinking like trying to decide between cohort, case control, cross-sectional, I would ask questions about can you measure the exposure after the outcome, right? Is it a case where that makes sense or are you not going to be able to do that? In which case you need to do a cohort study and measure the exposure before your outcomes happened. Does prevalence tell you about incidence? If yes, then you can do a cross-sectional study. If no, then you probably want to do a different type of study, a cohort study or a case control study. And then finally, the practicality issue. How much time and money do you have, right? Is this something that is going to be, a multi-year study, or is this something that we need to get some sort of hint about what the answer might be short in the next year, and go on, and then plan to go on and do a longer study later. So resources. There are a number of good textbooks. So the Rothman textbook I really like, Epidemiology and Introduction. And so it's pretty short. It's actually pretty readable. Rothman has another textbook called Modern Epidemiology, which I would not recommend unless you have already read this book and thought about it for a long time, because it's sort of the definitive text, but it's not very readable. There's also this Principles of Epidemiology and Public Health Practice by the CDC. This one is good because it's free online, so it's accessible. This is the reference for the Finer and Pico criteria that I've used. It's called Posing the Research Question Not So Simple. So are you familiar with the consort guidelines for clinical trials? Yeah. So the consort approach is really, I don't remember exactly when it started, but it really was set up to make sure that people understood what was in the results of the clinical trial, right? So when you see the flow diagrams, that was something that consort said, you have to have a flow diagram. And there are certain types of pieces of information that have to be in reports of clinical trials. And actually journal editors will kick out clinical trials that do not follow those consort guidelines. So it's worth checking those before you even start your clinical trial if you're doing one. STROBE is something similar for epidemiology. So it's strengthening the reporting of observational studies in epidemiology. The epidemiologists have been less willing to sort of get together and decide these are the things that we're going to have in a study. So these are more guidelines. Some journals are going to want you to have them. There's a checklist that goes along with this and then a longer explanation of each piece. Particularly if you are not very familiar with writing papers, this can be really helpful because it really walks you through. Here's what needs to be in the abstract. Here's what needs to be in the introduction. Here's what needs to be in the methods, right? So it really just sort of walks you through piece by piece. This is the structure that the paper should have. In general, I think there's nothing in here that I strongly disagree about in the STROBE statement, but yeah, but people will not necessarily follow them. I would say more often than not, when I have to do the checklist, I'm like, okay, and there's maybe one small detail that I'll have to add, but generally speaking, once you've written enough papers, it's all sort of in there. So CCTS has a core for the biostatistics epidemiology research design. I'm part of that. And we do drop-in clinics, we do seminars and webinars, one-on-one consultation. The other thing on here that I don't have is I do a once-a-month pancake house meeting, and so you can come and bring any questions that you have. It's particularly useful if you're sort of working up specific aims or ideas about how you're going to design your study. So that's second Wednesday of every month.
Pancake House?
Pancake House.
5 points?
In 5 points. Yep.
What time?
7:45.
Thank you.
And if you're interested, I can get your email and put you on the mailing list. So that one's fun, totally optional, which means that people generally want to be there, which makes it better. Most useful early in study planning, right? So I've had a lot of people come to me and be like, I collected this data, what's my study design? How do I analyze it? Sometimes I can help, and sometimes I'm like, I don't know what you've done here. So, if you start earlier is better, right? So those conversations usually are less satisfying for me and for the person I'm talking to than if we start earlier in the process and thinking about, how do we do the design, thinking towards the analysis in order to get, sort of as much as possible to the cause and effect right? Because that's usually what we're trying to do. And this is my contact information. You are welcome to contact me. I might, depending on the questions, I might send you on, but I'm happy to talk to people. I really enjoy this kind of work. Thank you very much for your attention.
Are there other questions? So I have a sort of practical question. So you mentioned the matching your study design to the resources you have to do the study.
Mm-hmm.
So can you walk us through an example of when you decided, I mean, so there must be times when you decide you just can't do a meaningful study because the resources aren't available. So could you talk a little bit about how you think about that and what kinds of settings that happens and what the, how people can approach it if they encounter that? I mean, I guess one thing is you can limit the scope of your study to smaller questions maybe, but anyway, something I think all of us have encountered at various times.
Absolutely, absolutely. So a recent example, I'm part of, so it's a industry academic collaboration, and our industry partners are interested in, it's a cardiovascular disease. They want to know about RA, what are the risk factors for cardiovascular disease in people with RA? And I think it's a really interesting question. We know that people with RA have an elevated risk of cardiovascular disease, but then sort of within that, what are the risk factors? And we're sitting around this room, we're thinking about it, and our clinical partners are saying, yeah, this is a very important question. Right? So one of the cardiologists I work with is like, this I need to know. And the industry partners are saying, yeah, that would be interesting because they want to expand their indication, right? And so I'm thinking like, okay, what do I have access to? I've got access to the regard study, right? And I know I've got about 30,000 people who I've got data on. I know that RA, we've maybe got a couple hundred, right? Because we've looked at this. So I'm thinking, so that's a worry, okay? So that's probably not a good resource. And then, I've got access to Medicare data, which is great, it's huge, right? But we don't have, for Medicare, we have diagnoses, we don't have lab values and those sorts of things that we might be interested in.
And is Medicare data free, or it's been bought by somebody and is now open to the UAB community, or how does that work?
Okay, so then I'll get to accessing Medicare. So anyway, so the final decision there, and it was a group decision, was basically there's somebody else who can do this study better than we can. And, we could do something not great, and we could limit our scope, but we decided that we think we'll pass on this one, and we'll say, okay, go talk to these people over there. Who we think can do a better job, right? We could have recruited RA, but we just didn't have the resources to do that, to start a global study. Okay, so that's sort of, and I think that's pretty common. People do that a lot. To get to your second question about Medicare, so Medicare data is challenging. It is available at UAB. We can work with people, so it's available through the what's called the peer group, which is pharmacoepidemiology and economics research. It's not cheap or free. We can reuse the data that we already have for about $2,000. So we've paid probably close to $500,000 for the Medicare data that we currently have. Medicare will allow us to do a new project for about $2,000 to pay to them. But it's not the sort of data that, I can go in and just sort of mess around with. It requires specialized people with specialized skills in programming. So that piece costs some money. So, it is available. It's not, but there are some financial and logistical hurdles. But yeah, let me know if you're interested, because we can do those kind of studies.
But obviously it's better to pull the plug on experiment before you actually start doing the work, because it's not going to be feasible to do what you hope, than to have spent months writing your proposal and starting to collect data and then realizing it's not feasible. So.
And that happens too. I had a pilot study that I still love this study question, but it's just not, it's not something that I have the resources and the sort of skill set to pull off.
Okay, thank you all very much.
Thank you.
Sorry for prior doing it so smoothly.
No problem. It happens.
The other reason why I chose help you you can detect change in that measurement.
That makes sense.
But great talk. Thank you.
I would like to hear just like how
So the university-wide center requires members from at least 3 schools. We have membership.
Okay, thanks.
Medicine, public health.
Business.
I'm just wondering what are the challenges in that? The members of the center, it's actually paid by their